So I'm super excited to be presenting rashes because it's everyone's favorite. But we'll start. All right. There are only three images where I will require your participation, but everything else is just me talking. All right. So the objectives, we're going to evaluate pediatric rashes. We're going to try to use a systematic approach. The main objective is being able to identify benign or common rashes from the very serious ones. The serious ones are not as common. And then recognizing some of the red flags that we see. All right, so rashes make up about 6% of pediatric visits. This comes up to about 2 million every year. It's pretty common. Unfortunately, we don't get as much training, whether it be like medical school, residency. I think in peds residency, I had to pick an elective to decide if I wanted to do derm, but we didn't have it as one of the core electives. And this leads to a lot of misdiagnosis. So the literature actually shows that, so in studies that were done in the past, looking at ED providers' diagnosis and then comparing it to dermatologists, the accuracy ranged from about 20% to 66%, somewhere as low as 19%. This is really important because misdiagnosis can lead to a bunch of different things. So one, unnecessary treatment, sending the patient for referral for like ANI when they really don't need it, food and medication avoidance when they believe that it's a true like reaction to something that they took where it's really not. And then mislabeling as child abuse. Sounds a bit extreme, but I think there was a study where a patient went through like the whole child abuse path, ACS got involved, and then later saw derm later, and they said this was bullous and impetigo, not cigarette burns. So that's why it's important to be able to recognize these. So in terms of like your history, you want to make sure that you're getting a very thorough history, including your associated symptoms, fever, URI-like symptoms, bloody stool, anything that can, help you narrow down your diagnosis, asking about the distribution of the rash, the sequence, so where it started and, where it's going now, if there was a fever prior to or during, whether there's been any travel, exposure to medications, insects, new detergents, soaps, and even sexual contact, as we can see in Ghana. And then recent illnesses or sick contacts and immunization history. All right. So morphology matters. We do get a lot of, I love you guys, but sometimes you come and then, not all of you, but some of you, you're like, oh, just bumpy bumps, which I've actually had someone present and I was like, or can you at least take a picture into the media so that you can, that's a way to kind of get around it. Bumpy, sometimes it really does look like bumpy bumps, but you kind of want to just make sure that you know what you're looking at, you know what you're going to document, and you know how to present it so that the attendings don't come at you, here, what'd you say? Well, that's true, yeah. So looking here on this left side, so anything less than 1 centimeter would be listed on the left, and then, can you guys see my mouse? No mouse. Okay. That's okay. You see the mouse? Okay, nice. Yeah, okay. So anything on the left side is less than 1 centimeter and anything on the right is greater, but the mouse only shows up on this. So now I'm like discombobulated. All right. So macule is anything that's flat, not raised, just flat, less than 1 centimeter, and anything greater than that, you can go ahead and call it a patch. Anything papule would be anything that's like raised less than 1 centimeter, and papules can be even like tinier. You can see like 2 to 3 millimeters even. And then anything bigger than that, you can call it a plaque. And then vesicle would be any fluid-filled, clear, palpable blister that's less than 1 centimeter, and the equivalent of that would be a bulla or bullae. And then anything, going within the epidermis would be your erosions, fissures, which we can sometimes see in the corners of the mouth. Here we have additional ones here, so like petechia and purpura, which are, non-blanching. Petechia would be small, and then the purpura would be the bigger one that's more coalescent. All right, more morphology. So we're just gonna, you know what, my mouse is not really cooperating. Yeah, but it's not showing up here, so I'm like halfway. It's okay. Thank you. Let me see. No, that's okay, don't worry. Okay, so we have a list here. So we have the bulla, the macule, flat, nodule, elevated, greater than 1 centimeter. The patch is flat, not raised. We have the wheel, which we'll see in like urticaria, but usually, you can describe it as a wheel and flare when you have that erythematous base around it. So this is the wheel, and sometimes you can have that erythema around it. Scale is anything that is just flaky, desquamated looking, and then crust would be very dried, exudates on the skin. Fissure, more of like a within going into the epidermis. Here you have your papule, we've talked about, plaque, elevated and larger than 1 centimeter. Pustule has that pus underneath, vesicle clear filled. And then excoriations you can see in atopic dermatitis, where you had those linear erosions. Erosion, this you can see in like a burn or SJS, which we'll look at some more images later. And then lichenification you'll see in the older kids with the chronic atopic dermatitis that have just been scratching over and over or not really well controlled. And then you have a scar here, which is just hypertrophy of the skin. All right. So we're gonna do now lots of images coming up. So benign newborn rashes. The overall theme for this is that they are self-limiting and don't require treatment, unless I really specify, but majority of them don't require treatment. All right, so in newborn, so you're in the ER, you're a new attending, babies come in all the time, and then you have a baby that comes in with this skin, freshly newborn, 3 to 5 day old, right? When you see this, although in other skin disorders, you can see desquamation and it's concerning for other things, this one here in that newborn period, it's really benign, nothing really to worry about. It's pretty common in especially post-term newborns, especially like 41 week, or you'll see them having this skin kind of like flaking like this. Cutis marmorata is a skin change or skin finding that happens when it's cold. Again, benign. We see it a lot of the times in the nursery. I think maybe like once in a while. It can happen in older kids with fair skin, but a lot of times in the infants. And then harlequin colors. This is just a change that happens with just the gravity dependent areas. It can resolve within 30 minutes. I saw this a lot of the times in nursery, but I don't think I've ever really seen it in the ED. But just to be aware of it. And these are all normal, nothing to do, no intervention. All right. So now some of these pustular rashes, you'll start seeing some of these in the ER when they're coming in for like their Billy checks, because it's still pretty early on. You have erythema toxicum, happens, it's pretty common, 40 to 70% of infants, happens within day 2 to 5 of life, can last up to 2 weeks though. And here you have your 2 millimeter erythematous macules, though these will be kind of like the base, and then you have these little papules, and then they later can turn into pustules. Happen on the face, trunk, and the extremities. Versus transient neonatal pustular melanosis. Again, this one you'll mostly see in nursery. I don't think I've ever seen it in the ED, but just to be aware of it, happens mostly in melanated skin, 1% in white infants. But you have these fragile pustules. They later progress into scaling edges and then turns into these dark spots all over. But this is just one of the stages that we see here. Again, also resolves no treatment. And then you have your acne neonatal, which I think you guys see all the time. Happens, within the first month, can, last a little bit longer. You have a mixture of your comedones, your papules, pustules. And then think of this one as like your teenagers with the acne, kind of like a similar appearance. There's usually no treatment in the literature. And I guess sometimes if it's very severe, they can do benzoyl peroxide, but I don't think we have ever prescribed it, at least not while I'm in clinic or in the ED. We prescribed any medications for it. They can just follow up with their PCP. And then we have milia and miliaria. So milia would be your keratin retention papules that happens around here. Can also be on the cheeks, on the forehead, resolves and nothing to do here. And then miliaria is basically your heat rash. And the way I try to remember this is miliaria sounds like malaria like the fever with the travel. This one's just the heat version of this, because these two words can be confusing at times. So then this also happens in 40% of infants. Crystallina versus rubra. I mean, we don't have to know this because it really isn't that pertinent because they all look the same essentially, but the rubra would be on the covered areas and then crystallina would be on the head, neck, and trunk. How did you put the mouse on the screen?
It's the second screen.
Oh, I see. Okay.
Extended.
Wow. Okay. Yeah. All right. All right. So this is the first image where I'm going to need a little bit of your participation. Can someone describe what you see? And it's just straightforward, or what you think the diagnosis is. Nice. Someone said crust. Erythematous, yes. There's one word I'm looking for. Scaly. Who said that? Nice. Woots, woots. All right. So I should have given you guys a chance to diagnose, but so this is seborrheic dermatitis, aka cradle cap. And this is pretty much greasy scales. You know, when you're presenting, once you say like this erythematous, greasy, scaly, kind of like lesion on the patient's skin, we will know exactly what you're talking about. So it happens within the first and second month of life. Again, when you're examining the patient, not only look at the face, but look behind the ears, look within the hair, you'll see these scales. And even if it doesn't show in that moment, ask the mom, have you noticed any like scales or kind of like dandruff-like things falling off? And they'll be like, yeah. Usually there's no treatment. When the patient comes into the ER or even in clinic, you can tell them, you know, if it's pretty mild, do coconut oil or mineral oil, wide tooth comb or soft brush and pour it in the baby's and just like comb it and try to get the flakes out, and that should resolve. There are some instances where it's like very severe and you need to do a little bit more, and then we can prescribe the ketoconazole shampoo where they can do it like 1 to 2 times a week or so, not that often. And then there's been, you know, times where you prescribe the low potency hydrocortisone, but we try not to prescribe hydrocortisone for the face for babies as much as we can. And then here we have atopic dermatitis. So in the infants, it's a little bit in terms of like the distribution, it's more so on the face. It can also be, you know, on the forehead as well, but you have this like erythematous scaly plaques on the cheeks versus when they're older, you can see it a little bit more within the flexural regions. Again, emollient, so tell them as soon as you come out of the shower, slap on the Aquaphor, Vaseline, whatever you have to lock in that moisture. And then if they have areas that are really inflamed, super red, they can apply the hydrocortisone. All right. So we tend to see a lot of this diaper dermatitis. I will say that although the slide is showing it, you know, discreetly, sometimes they come in and it's like mixed, like not super exclusive. So candidal dermatitis, you can get that from prolonged, having prolonged moisture, baby sitting in the diaper for about like 10, 12 hours, not being changed, or recent antibiotic use. So you're looking for this beefy red rash with satellite lesions, which are these like little papules, pustules around. And here you can see that it's within the skin folds. And that's what differentiates the candidal from the regular irritant diaper dermatitis. Again, well, here you're using nystatin. You want to tell them to use it for about 10 days. Even if it's, you know, getting better, just complete it. And then you can also add desitin, which is the zinc oxide, with it. So sometimes when they come in, it's really hard to tell if it's one or the other or both. When in doubt, you can always, you know, like mix it or alternate and try to, you know, get them to do that regularly, and that should help clear it up. Tell them to keep the area dry, change the diapers frequently because you want to kind of prevent it from getting worse. And then you have your irritant diaper dermatitis. Again, you have the redness, shiny, eroded areas. This spares the skin fold. You want them to, you know, change the diaper frequently. And then gentle cleansing is really important because sometimes parents will see a rash and then they are like trying to clean. They're like, I'm doing more cleaning. I'm keeping the area nice and clean. And then they're just like wiping and really scrubbing really hard. Tell them to just be gentle. And, you know, they can dab. They can just do like water and just try to avoid worsening that irritation. And then this one is perianal strep dermatitis. I think this one's Dr. Khan's favorite. She is the one who kind of like, she kept bringing it up, like, you're looking for that diamond shaped, area that's like pretty well demarcated. So this one here, it's very bright red. It can be painful. Sometimes they may have bloody, streaked stools when you're doing your exam. Just make sure you're fully examining, looking for fissures or anything that might, hint at, worsening irritation. But for this one, you essentially want to treat with amoxicillin because it's from group A strep. And then, I mean, I don't know, do we often swab? Usually it's a clinical diagnosis, so you should be able to,
It's very self-limited in where it's at.
yeah. But it, theoretically, I guess you can swab and then get your results later, but by then you probably would have already been treating this. And then if you're worried about, some staff involvement, you can add me person. Okay, so that was kind of like the baby stuff. So now we're moving on to a little bit, older, common pediatric rashes. So I think about a year and a half or a year ago, we did a research study with some of you guys, where we had the EM and the peds residents do a visual diagnostic challenge. And I'll show you what some of the images looked like, but you guys pretty much had to guess what you thought, make your diagnosis based on, we had 12 images, and then we had accompanying vignettes. So these images were validated by our 2 dermatologists in the derm department. We initially started off with 22, and then we had them individually diagnosed, and then we selected the ones that had 100% concordance. So there was no like confusion as to what this rash could be. We had 22 answer choices, and then we had you guys rate your confidence levels. So this is a sample. This is what one of the rashes looked like. This one was actually a freebie. It was really, I think you guys across the board got like 95% correct. So this was the accompanying vignette, and then this is what the choices on the side looked like right here. I tried to do it this way so that, because when you're in the ER, it's not, you don't have 4 multiple choice. You just have to think of what you think is going on. So trying to keep it standard and just having all these for each image. All right. This is the second image. Can someone describe this or just throw out some things that you see, or if you feel like you can diagnose it, go ahead. Okay, nice. Yeah. I hear some. Good enough. Yes. All right. So that was one of the images in the study. And as you can see here, a lot of people got pityriasis, right? But some people, were confused as to whether this could be nominal eczema. And I think a few people put like viral exanthem. So in all of the images, only 2 had statistically significant difference. And those were these 2 images. EM, I will say, did better in those 2 images. Don't get excited. No, actually you should. You should be proud of yourself. I think this also, it's because like, this tends to happen in older children, but yeah, you guys did well for these 2 images. And then as you can see on the bottom, this one, I'll just tell you it's eczema herpeticum. But a lot of you were confused between atopic dermatitis and eczema, which is understandable because it's like the underlying illness. And as you can see with the increasing PGY level for this rash, you guys did better. And this was also statistically significant. All right. So pityriasis rosea is what you guys said. You're looking, so initially, you're looking for this discoid, like multiple discoid lesions and a Christmas tree pattern. But sometimes if you look, you may be able to see like the remnants of like a herald patch. Or if you ask the patient, did you see a large patch before? Then they might be able to tell you. So it's thought to be from a viral or even stress, so HHV6, 7 or stress. It's intensely pruritic, and it can be associated with some fatigue, malaise. This really lasts a long time, 6 to 8 weeks. But essentially is just supportive care, giving them maybe Zyrtec to help with the itchiness, telling them to hydrate their skin. And there's been instances where, people have tried to recommend steroids, but not as, it's not first line or like very needed in most cases. Scabies from mites via close contact, also intensely pruritic, worse at night, but you have these linear burrows within the skin, overlying excoriations. You want to look between the interdigital spaces, the wrist, and then the waistline mostly. You'll see this. The treatment for this is permethrin. And then you also want to treat the close contact of the patient. So I think sometimes we send some extra medication and tell them to give it to them instead of having them each come individually, sorry. And then you have scarlet fever, again, your papules. But with this papule, it's not like, hand, foot, and mouth also has papules, but this one is more sandpapery and fine. And you may have other associated symptoms such as your, pharyngitis, lymphadenopathy. And then Pasch's lines are just these erythematous papules within the creases. This right here, the blue arrow showing. Penicillin or amoxicillin for 10 days. And this is just a notable mention. I've seen this twice, only because we kind of weren't sure, and then we tried to get a derm follow-up, and then they said, oh yeah, this is inverse pityriasis. So inverse pityriasis rosea, it's exactly as pityriasis, is just inverse because it's not in the typical distribution. So like on the back, on the trunk, you'll see it in the creases. So like within the folds, and then the antecubital, sometimes even the neck. So just to keep in mind that this tends to happen as well. And then I'm just going to skip through this because we've talked about atopic dermatitis, but this is what it would look like for the older children. And then also here you see. All right, this is the last. No, it's not. I lied. All right. Description or diagnosis, or what you think it is. What do you see? Okay. Someone said vesicles. Okay. Crusting, yeah. Different stages, I like that. Someone says cease pain, okay. Rumpy bumps, okay. Can we get some diagnosis out there? Throw it. I can't see you, so I don't know who. Okay, ooh, who's that? Wow, okay, nice. That was Sean. All right. So yes, so that was eczema herpeticum. And I know the image didn't show the full thing, but it spared the palms. And then as you're looking here, you can see these like ulcers / erosions as opposed to hand, foot, and mouth. They're just like mostly papules. You may have some vesicles here. I've seen a couple of patients that have like that blister in here, but this one is very specific. And then look at the gums also here, right? Hand, foot, and mouth really doesn't do that. This is more HSV type of thing. So you'll see these grouped vesicles, pustules that ulcerate. And then going back to hand, foot, and mouth, this is so common. I think in the summer, we wouldn't even want to hear the presentations. We were like, okay, thank you. And then just discharge the patient. So you guys have seen it. It's, red flesh colored papules on the palms, soles, and then a lot of times in the buttocks. This year I saw a lot that were in the buttocks, and the parents were like, yeah, that's so weird. And for me, that was also new because prior to that, I would only see it in like hands, foot, mouth. But if you see it in the diaper region, don't be alarmed. Again, supportive care, Zyrtec, 7 to 10 days. No school, especially, I usually try to tell them with the fever, but then the schools tend to freak out even. Yeah, so just keep them out of school.
As long as no new lesions
Mhm.
are popping up, and the older lesions have scaffold.
Yeah.
It'll take a while for the rock to completely go away, but as long as new lesions aren't popping up and the old lesions are scabbed over, then they can go back. I would give them a note. And they have to be come back.
You said, and they have to what?
Fever back.
Oh, yes.
Come back for a note. Give it them like 10 days later.
Yeah, give them the note. And then the one thing that you can sometimes tell them is the nails
Oh, yeah.
tend to or not always, but it can start falling off and the parents will freak out. So you'll just let them know, hey, there's a chance that the baby might lose the nails, and they're like, oh my God, really? And you're like, yes. So comparing that to impetigo, and you have these gold crusted lesions here. Sometimes it'll be, here, child digging their nose and then getting it all over. But if it's pretty localized, you can prescribe mupirocin versus if it's like in multiple locations or if it's pretty severe, you can do Keflex. You can add Keflex to that. All right. So one way to remember the palms and soles is this mnemonic in step 1 book cars. I like cars, like electric cars, because I can add the erythema multiforme because you can also have that. But the C is for Coxsackie A, as we see in hand, foot, and mouth. R for Rocky Mountain spotted fever, and then S for syphilis. All right, this is the last one, I promise. What do you guys, can someone describe or? Okay, I'm hearing ringworm, what else? Periodic, what? But yes, periodic, yes, I like that, okay. Oh, central clearing, yes, you guys are killing it, all right. Raised borders, yes. All right. Guys, I get excited. Okay, sorry. All right. So this was wait. Yes, okay. So this was also an image in the study, and as you can see, a lot of people, majority actually chose tinea corporis, and only a handful chose granuloma annulare here, and then some people thought this was nummular eczema. We also had this image here, which was tinea, but you see how it was like split between the 3. So we have granuloma annulare, nummula, and tinea. So as you can see, this can be tricky. Even for us in the ER. So a lot of the times I feel like if I see tinea, I'm like, okay, yeah, this is tinea, I know. But it's when it's something else, when I start to question myself, I'm like, could this be or not? So for nummular eczema, usually it'll be like chronic. A lot of times if you ask the history, they'll tell you that, oh yeah, they've had it before, and then we do this steroid or cream, and then it gets better. But essentially you're looking for this well-defined scaly coin-shaped plaque without any raised borders. So the lesion itself can be like slightly elevated, so like a plaque, but the border shouldn't really be elevated. I think of it as like a coin. Versus tinea, which I think of it as like onion ring, is just like very scaly annular rings with the raised borders, which you see here. Very scaly, as opposed to granuloma annulare, which you also have the raised borders, but it's smooth. You shouldn't have any like scaliness to it. So tinea has a combination of both, so raised and scaly, but this one shouldn't be scaly, and this one shouldn't have like raised borders. For the treatment, similar to the atopic dermatitis, and then for this one, if it's tinea capitis, you want to prescribe PO because you want it to be able to penetrate the follicles. So not just like, the topical for the skin, but you want griseofulvin or something PO. And then for granuloma annulare, it's self-limiting, but it can take a long time to go. It can last for months to years. So this, you just try not to confuse it with erythema multiforme. I'm just going to touch base on this briefly. We had a patient that came in, I think Dr. Rallo and I came in twice. So the first day came in and you saw this like wheel and flare. It didn't look like nicely targetoid, just wheel and flare. They said they ate something, didn't know, had a laundry list of like allergies. And then we gave medications, but then came back 2 days later and said, we're doing everything. It's not helping. It's getting worse. And then we noticed exactly this, at which point we made the, clinical decision that this was more so erythema. And we couldn't really identify anything that ate specifically that brought it on, but it's thought to be a hypersensitive reaction to either viruses or medications. And they can have like general feelings of unwell, like malaise, headache here and there. So differentials would be urticaria, and then erythema marginatum is what you'll see in acute rheumatic fever. HSP, you'll see these palpable purpura on the buttocks, legs, associated with the GI, either GI bleed or increased risk for intussusception, sometimes joint pain, and then some renal involvement as well. It's supportive, but in very severe cases, when there's organ involvement, you may consider steroids.
And those are when?
Yes.
really important when you're describing the rash.
Yes.
It's erythematous, be blanching.
This is blanching, so.
No.
Mhm.
Non-
Oh, non-blanching.
Non,
No, this is non-blanching because it's outside of the
Yeah.
vasculature, yeah.
when you're describing the more benign rashes, you may not, this is a great presentation
Mhm.
on all the differentials, you may not get to make the diagnosis, but to be reassured that it's a benign rash, because erythematous is blanching, but a non-blanching rash is more concerning for some of the,
Mhm.
sepsis.
Mhm. So non-blanching versus your viral rashes that will be blanching because they're within the vessel. Although measles can start off blanching and then later turn to non-blanching. So with these viral rashes, measles, yes. You have your high fever and your 3 Cs, your cough, rhinorrhea, conjunctivitis, your cup-like spots, which are these like bluish, whitish spots within the mouth that happens before the rash, and then you have this maculopapular reddish, brownish rash. Now, these two tend to be mixed up or confused. Erythema infectiosum is the slapped cheek. This one, you have like this concurrent, like URI-like symptoms, low-grade fever. But in roseola infantum, this one, you have the high fever before, right? 3 to 5 days. And once the fever resolves, you end up with your rash. And the way I think of this is that, roseola for the rose, like in 3 to 5 days, the petals start to fall off. So in 3 to 5 days, you start to see the rashes here. And you have these pink macules or papules on the trunk. This will start off probably like around the neck here and then go outward. So centripetal versus centrifugal, where it starts up here and then goes more centrally down here. And again, this is similar image, just showing you the differences here. Complications for measles, pneumonia, and encephalitis. Complications for fifth disease, the parvo, you have to tell the pregnant women to stay away, at risk for miscarriage, and those with sickle cell can have aplastic anemia. And then roseola, because of the very high fever, they tend to have some febrile seizures. All right, last section. Now we are at the life-threatening can't miss rashes. All right, toxic shock syndrome. So this one is toxin mediated by staph, strep. You'll usually see this in women using tampons or post-op infections like surgical wounds. You have this diffuse sunburn-like erythroderma. This very flushed skin. I heard the appearance doesn't hurt like a sunburn, but essentially after that initial illness, you can have desquamation later. But with that initial illness, you'll have some confusion, high fever, vomiting, diarrhea, hypotension, all signs of multi-organ dysfunction. You want to, treat empirically, broad spectrum IV antibiotics like Clinda, Vanc to cover for MRSA, and then aggressive fluids or shock management. So if they need vasopressors, the mortality is 5 to 15%, even with early intervention, but of course higher if delayed. Staph scalded skin syndrome. So this one is Staph aureus exfoliative toxin, which results in epidermal detachment. Mostly happens, you'll see, it's very rare, so like 0.5 cases per million patients per year, but when it does happen, you'll see this in infants and young kids. 3 phases you have. The first phase, erythroderma, so which is this erythema, tenderness. Phase 2, the exfoliative phase, where you have the sloughing off of the skin, which we call, do you know what sign? Right there, yeah, this one. And then the phase 3 is the desquamation. So this here can happen within 24 to 48 hours, and then days after you can have this. The treatment, just to mention, you can have this perioral crust without involvement of the mucous membranes. And this is in comparison to SJS and 10, which we'll talk about later. That involves the mucous membrane. This one does not. For IV antibiotics, you have nafcillin, oxacillin covers for MSSA, and then Vanc and Clinda will cover for MRSA if you feel like there's a concern for that. Supportive care, burn care, so whether it be your bacitracin, Zeroform, just gentle treatment of the skin. There's an excellent prognosis in kids, but not so much for adults and immunocompromised. Meningococcal disease from gram-negative, you have the rash, which is like starts off petechiae and purpura and can progress rapidly to this coalescent hemorrhagic lesions and sometimes even necrosis. And you see all of this here can happen: meningitis, shock, multi-organ failure, DIC, and then Waterhouse-Friderichsen, which is your adrenal hemorrhage. Here you have IV antibiotics, ceftriaxone or penicillin, aggressive supportive care, and then prophylaxis, your close contacts. I think they like to test this, and we did this recently, like rifampin, or sometimes cef. Vaccination for your teenagers, and then for the mortality is about 10 to 15%, but you will have long-term neurological deficits or hearing loss. This lady here is a Brazilian swimmer who had meningitis prior and had to have her limbs amputated, and she's also deaf, but she is killing it in life. I think she was in like the Paralympics. Steven Johnson's, this one is a severe mucocutaneous drug reaction. You'll have the mucous membrane involvement, fever, malaise, you have the skin pain, these targetoid macules that, turn to vesicles and bulla. The difference between SJS and 10 is that SJS is less than 10% of the body surface area, and then 10 is more than 30%, although I think the name should have been switched to make it easier to remember, like 10, but you want to stop the drug. Again, same thing: burn, care, fluids, pain control, and then the mortality increases with the increasing body surface area. All right, second to last one, and then we have one last one. DRESS, drug reaction with eosinophilia and systemic symptoms. So this one I have actually never seen in residency or in fellowship, but it's a severe delayed hypersensitivity reaction that happens 2 to 6 weeks after drug exposure. It's believed to be from like a combination of like just hyperimmune, so like T cells, cytokines, eosinophilia, all kind of like having a party. The anticonvulsants that are implicated here would be more of your like aromatic anticonvulsants, so like phenytoin, carbamazepine, and then you have allopurinol, your sulfur drugs like Bactrim, Vanc. Blood work will show eosinophilia and some organ involvement, so you can have myocarditis, pneumonitis, ARDS, nephritis, and then elevations in your liver enzymes. But you essentially have this diffuse morbilliform rash. Again, stop the drug, supportive care, and then steroids. I've seen that, when it's not as severe, they may do some topical, but when it's severe with the organ involvement, they can do PO steroids or IV. It has a good prognosis if caught early, but it can relapse and there's long-term organ dysfunction. There's actually that's it. And then last one is Kawasaki, which we know. So this one, you have your typical versus atypical. In your typical, you have fever for more than 5 days and then at least 4 of the 5 symptoms. So your conjunctivitis, your mucous membrane changes, your extremity changes, and your cervical lymphadenopathy at least greater than 1.5 centimeter. And then, the rest of the rash. This is actually a baby that we had in my second year of residency who was like, I think 6 months or 4 to 6 months. I think it was like the youngest case we'd ever seen. So we did a case report on that. But the baby had this like maculopapular rash and then peeling of the extremities. And then of course in the atypical, you can have less than 4 of the symptoms, but you need your additional criteria to diagnose it. So like anemia or thrombocytosis. And the reason we worry about this so much is the risk of the coronary artery aneurysms. So you'll have your baseline echo inpatient and then follow it up outpatient after the IVIG and everything, just to see if there is or if it develops later. And that's pretty much it. This is my summary table, divided up into the non-life-threatening, life-threatening, can't miss, and then your Nikolsky signs. And that's it.